I'm in my fourth cycle, and at the end of the first cycle, I had a very good response. It was 90%, and I'm told that if it goes down quick, it can also go up quick. Are there any statistics that you want to throw at me or dissuade me from that thought?
I mean, it is true that the patients who have the most rapid fall have most rapid improvement have the quickest fall, but a lot of that data is from before we have, our current quadruplet therapies and other therapies that relapse, and, augmented maintenance therapy. So, I don't think I would worry too much about that. As long as you're responding nicely, that's the important thing.
Yeah, I mean, I would agree, obviously, but now with the use of, are you getting quadruple? Yeah. So, I mean, we've seen incredible, then it's like, well, do I really need 4 cycles? But I think a lot of it depends on how you present it and some of the abnormalities, the cytogenetics, and so. But the idea in the past was that it took a while for these plasma cells don't differentiate that rapidly, and so it takes a while for them to die. And so if you have a rapid response, it might be a more aggressive, more prolific. But not, I mean, now with the new agents, if you have kind of standard risk, but yeah, a remission's a remission, like, that's fantastic.
I might add just one thing that, while we care about the pace of decrease overall, what we care about the most is ultimately the depth of response. And so while we love to see a rapid drop, we really want to see how far it can go down. And so the analogy I kind of make is that myeloma is like a slug. It's just really hard to kill, but you can put a lot of salt on it. And so the idea of the therapy is that you're just dumping a lot of salt, and the more salt you can then keep on with maintenance, it just lets that disease stay in that low level state. And that's the whole goal. And then that's where people do well. They live well, they feel well, and that's the goal of therapy.
Hi, just a question about CAR T cell. I'm over here. Hi. When it comes to capacity and demand for CAR T cell therapy versus supply, can you address what that looks like, just in general, broadly?
Yeah, I mean, so supply and demand is a big deal with CAR T. I mean, in the first couple years, it was a bigger deal. There were limited slots, very poor production capacity. Now, I think both companies have stepped it up significantly, and it's not really that difficult to get a slot for a collection. But now that we have available second line, I mean, yes, we don't have enough capacity to do 30,000 myeloma patients every year with CAR T every time a patient's having their second line therapy. So I think society-wide, it's a bigger question. Can we maintain this CAR T for early line therapy? It's not just a matter of how many slots for the CAR T collection. We also have institutional capacities. We have how many patients can we get through for a bone marrow biopsy in a week, or a PET scan. The PET scanners can be limiting. PFT slots and echoes and all these things we have to do for the workup. Not to mention the man or woman power doing all the, in charge of all the workups. So yeah, it's not going to necessarily be for every patient, but definitely it's going to take a discussion with the provider and figure out if it's going to be something right for each individual patient.
Yeah, I think, as Dr. Anderson said, like initially, unfortunately, we often couldn't get, enough time to get a slot, and now generally that's not a barrier at all. But just like talk about this sort of such a diverse disease, yeah, not every second line patient probably needs to consider doing CAR T, and not every relapse is the same. There's sometimes a florid relapse, there's sometimes just a gradual laboratory relapse, and so as of right now, it doesn't seem like it's certainly not like it used to be in terms of, but it requires that you come and hang out with us for a little bit in Dallas, and so you don't live around here, that can be a barrier.
First, I really like your socks.
Oh, thank you. Some of my patients know this. My wife has signed me up for the Sock of the Month
Oh,
club.
good. Well, you're
And they're
keeping up.
terrible quality socks. They only last a month. That's fine. You get a new one
get
the
a new
next
one.
month, so it works out okay.
Put some more salt on. So I have a seizure disorder controlled with Delant. Is that going to preclude me from, I think the CAR T was one that where seizures was a possible side effect.
So in general, seizure is one thing that we worry about with CAR T therapy. That's part of the constellation of symptoms that happens with neurotoxicity or ICANS. It is not an absolute contraindication, but it is something that we generally require neurologic consultation and to make sure that the seizure disorder is already well controlled, because we're adding another insult to that situation. And so even people who don't have a pre-existing seizure disorder, they are put on some sort of anti-epileptic drug as a preemptive measure to it. So in your situation, that may need to be upped even further. And again, it just may depend on your history and other particular details.
No more questions, we're done.
I would also add, I mean, in general, at least my experience has been the neurotoxicity with CAR T for myeloma has been, acute neurotoxicity has been very manageable and very minimal.
Yeah, very,
For
very
lymphoma
different.
is another story. Like,
Yeah.
although might have been excluded from a trial, I think if you have a well-controlled seizure disorder with myeloma, with the products that are out now, I don't think that would be a contraindication.
Hi, I was just curious about some upcoming things that I've read about, the tri-specifics, the quad-specifics, and then I read something about killer cells too. And I didn't know, I didn't see any of that in the presentation. I was just curious what you thought of that stuff. Or
Yeah.
how far is it away?
Sure. So yeah, that's a very exciting area. I actually just gave a presentation to the B'nai Tara Foundation about some of that a couple of weeks ago. So within the realm of what we talk about, some of these monoclonal antibodies, they can be divided up into different ways. And when we talk about their structure, function, capacity, they can be divided up as what are considered naked or conventional antibodies, classically that Y-shaped structure that I showed you. They can be talked about as antibody-drug conjugates, or ADCs, also simply called conjugated antibodies. And that's like belantamab mafodotin, which you've just heard about. And then there's this whole realm of bispecifics, trispecifics, and tetraspecifics. These are called multispecific antibodies. The three that we have in multiple myeloma you've heard about, those are the bispecific antibodies. But in develop, there are NK cell antibodies, and then there are trispecific antibodies, and then further down the line will be the tetraspecifics. The idea behind all of these is that they are all within the realm of immunotherapies, and they're intended to use different portions of the human immune system to target myeloma. So right now, what we have is we can use CD3 positive T cells in using an antibody or CAR T cell to attack myeloma. But in development, we're going to have drugs that can use the NK cell pathways to then target myeloma. And then the trispecifics, since you asked about that specifically, are a little bit further down the line, but are intended to bring in two targets. Where the future will probably go is unclear, but what we envision is that we may have a lot of drug sequencing that we could do. So for instance, for some of the ways that bispecific antibodies don't work, there's two main things. One is that we talk about T cell exhaustion. So if you're using a T cell pathway to attack myeloma, at some point you can deplete that pool of effective T cells. And then we talk about antigen escape or antigen resistance, where the target on the myeloma cell dissipates. You beat it up enough. So you can envision a future where, let's say you use a T cell bispecific to attack, let's say, BCMA. Great, it stops working. Then move to maybe an NK cell antibody with a different antigen, let's say GPRC5D. And that sort of sequencing could allow for very effective and deep responsive against myeloma and potentially a number of cancers.
And just like we have, we're exploring the use of NK cells with trispecifics and bispecifics. Likewise, we have currently we're using CAR T cells, but they're also looking at CAR NK cells, CAR macrophages, putting that receptor into other sorts of immune effector cells to bypass their resistance.
And going back to just the cells, because we don't, I think, talk about enough about NK cells and just biology. When we talk about lymphocytes, everyone knows the B lymphocytes and the T lymphocytes. The NK cells are kind of forgotten, but they're there. They are lymphocytes as well. They're just kind of that forgotten third category. And then there's an even more funky entity of the NK T cells, which are natural killer functioning T cells. So that's where sometimes it gets confusing what we're talking about, but there's just a lot of cells that we can use.
Yeah. You gotta go. And then, I mean, also expanding off-the-shelf allogeneic CAR products. So, part of the idea is, again, hopefully, perhaps as we layer in earlier in the treatment course, but oftentimes after 5-6 lines of therapy, one's T cell function, T cell exhaustion, these are significant issues. And so there are now off-the-shelf allogeneic from healthy donor cell lines that are being looked at in a variety of malignancies. And that anytime you say off the shelf, that is a nice, as opposed to having to collect and getting a slot and collection and manufacturing, as opposed to, that was a big deal initially. It was nice to have an option that you could get to quicker in this disease.
Okay, I'm going to put you on the line. I hear, and it's wonderful, there are a lot of treatments coming up. It seems like they're all to lengthen the response time for as long as you can until there's another treatment to push it on down the road. Is it realistic to believe that there might be a one and done or a cutoff point where, no more, you're cured?
I mean, the problem is, what is the definition of cure for myeloma? How can we say it's a cure unless they're beyond 10 years out, and
Right.
until we have 10 years of follow-up for any given particular
So
treatment?
there's not enough, 10 years would be a magic.
I mean, and that's, yeah, if you draw a line in the sand, that would probably be a reasonable time point, although I have plenty of patients who've had more than 10 years of remission after transplant, and, but we still worry that they could still relapse. And so even then, are they really truly cured? And then we usually still have them on maintenance therapy because we don't know if they need it or not. I mean, is the patient that I mentioned earlier today that's 6.5 years out from CAR T and on no treatment, despite 9 prior lines of therapy, is she cured? I don't, we can't necessarily say that yet. We're hoping that there are some of these patients that have gone through CAR T that are cured and won't ever have a relapse, but we just need further time to really know.
We're a lot better at the more acute illnesses, more diffuse illnesses like leukemias, where the MRD testing, we can say, at certain levels of remission that translates to whatever, a functional cure. And I just think, although we're, getting there and getting better at what is MRD, how to test it in multiple myeloma, because there are some interesting where people that do seem to obtain a level of MRD negativity in multiple myeloma, that we might be able to take them off maintenance and not expose them to lifelong immune modulating drugs, for instance, that can, but not there yet.
I am concerned about having healthy enough T cells for CAR T. And I understand they come from the lymphocytes. So is there a low lymphocyte level that I should be concerned about? And second question, is there an age limit, cutoff limit for CAR T?
All right, sure. So, if your lymphocyte count is under 0.5, it's going to make it very difficult to collect enough T cells for the product. It's still possible though. But yeah, the patients that have lower lymphocyte counts, we may tend to collect longer that day or collect more volume of your blood just to make sure we get enough. But there's not necessarily a lot of studies saying, oh, you have to have this level, or we do have studies looking at T cell fitness, markers of T cells that indicate that patients that have more naive phenotype or more memory phenotype T cells have better outcomes and longer remissions than the ones that have an exhausted T cell phenotype. But we don't really have a commercial assay that we can do that for any given particular patient outside of a trial. But yeah, so I think there's more to come on that. And then you were saying, yeah, what was the second part of it? Yeah, so age, so there's not really any specific age cutoff. I mentioned earlier, I gave CAR T to a 90-year-old recently, and they're 7 months out doing fine. It's more physiologic age. I would say it's, in our experience, CAR T is generally a lot less toxic than a stem cell transplant, for example, that, I probably wouldn't really routinely offer a stem cell transplant to anyone over 80 probably. But yeah, CAR T is, you might have a couple days of feeling rough, but other than that, it's typically not too bad. Yeah.
And outside of just the T cells quality and quantity, behind that, it also relies on a certain physiologic response of your body that the T cells would normally have. And so when they're reinfused back into you, when you take out like a normal T cell, they get re-engineered into CAR T cells and they come back into you. It's not just the cell itself that's important, it's what is within that immunology that allows it to really mount the response that we're looking for against the myeloma. And that's even more of a black box because we just don't understand all the details of those interactions.
Over here, so my question is about MRD testing. Are we still limited to bone marrow aspirations, or do we have any other options in the future?
I guess I'll start that then. Okay, so you can ask 10 different myeloma docs about MRD testing in any sort of way, and you'll get at least 11 responses. So minimal residual disease testing or measurable residual disease testing is kind of like the deepest response that we have to look at myeloma. And it used to be able to look at 1 in 10 to the minus 5th cells, but now it's 10 to the minus 6th. So that's 1 in a million. Right now, because that is so sensitive, the only meaningful way to do it is really on bone marrow aspirate. That's where, just backing up, plasma cells live in the bone marrow. Multiple myeloma is a cancer of the plasma cells. So we go directly into the bone marrow to then see what is the situation of the myeloma. And so when someone has a bone marrow biopsy, that first very initial sliver of a pool is what we like to send off for MRD testing, because that's where we have the greatest probability of finding any sort of active disease cells within that sample. It's not that you couldn't run it off of any random sample per se, it's just not meaningful to do so. So that's one, yes, limitation, if you will, of that. Beyond that, and this is where I'll defer to my colleagues for their added input on it, what do we do then about MRD testing is still very much a kind of a controversial question. We certainly had an evolved understanding of the biology behind it, and we talk now just not about MRD testing and MRD negativity, but sustained MRD negativity. But how it translates into the day-to-day practice and what do we make of it all within the greater context of a patient, still very much unclear.
I mean, we know.
So mass spec is very different. So when we talk about the monoclonal proteins, the two main methods that we have of detecting that are protein electrophoreses, which are literally over 100 years old, and a mass spec, which really was from a few decades ago. So that is looking at the protein production, the antibodies themselves. That is not the same as looking at the cells. So with MRD testing, we're looking for the cells, and we have two main routes of doing that. We have a genetic way of doing that, and we have a next generation flow cytometry way of doing that.
And as far as MRD testing, we know that the patients that are MRD negative have the longest remissions. The ones that have sustained MRD negativity for a year or more have the best, longest remissions. But we don't really have data saying that, if you're not MRD negative, you're going to do poorly. I mean, we have plenty of patients that have detectable disease that can do quite well. It's not the end of the world if you're not MRD negative. It's really more like a population level for these trials. This particular treatment we know induces such and such percent of MRD negativity. It really helps establish this treatment's very effective, but just because you're not one that has completely MRD negative disease doesn't mean that you're not going to do well. We've got patients who even have persistent small M spike for years and years and years that can do quite well as well. Obviously, the ultimate goal will be to get into MRD negativity, but you don't have to, just because you didn't get there with the standard treatment doesn't mean you have to go, hitting it with a sledgehammer to try to drive that further down.
like at what cost to get to MRD negative. And it's probably more, a lot of it's related to the therapy, but also the disease itself, that some people might get to MRD negative with Velcade Dex, like, very minimal therapy. And so at what cost to get to that MRD with toxicity? But I also, thinking about the orange peel and rhubarb days, when they first described myeloma in the 1800s, whereas like leukemia is a diffuse disease, myeloma can be very patchy. And so doing a random sampling of iliac crest bone marrow aspiration it may not totally reflect, you might be, some patients present with multiple plasmacytomas, and yet you do a marrow and it might be completely normal. But if you aspirate in a lesion, it'll be 90% plasma cells. So that also is a difference in MRD testing in myeloma, because it can be kind of a patchy illness, not completely represented by just an aspiration.
Okay, so my question was pretty much answered with your question. So I have multiple myeloma and I'm being seen by Dr. Khan. So for you two gentlemen on this side, how many more years have I got
Your
left?
answer.
How long am I going to live?
As long as you want.
Okay, good answer. Hey, but the question was, her question was about when you see the drug that is the end-all, save-all. And you said that you had somebody that was 9 years in remission without maintenance?
Oh, so the one, 6.5 years out from CAR T with no maintenance. I've got several patients that are 10 or 15 years out from transplant. Well, some of them are on low-dose maintenance, some are not on anything for years and doing well. So it's hard. And we've got a couple that are 17p deletion on, just lenalidomide maintenance for a decade and doing fine. So it just goes to show that the markers that we think mean high risk don't always equate to high risk either.
Yeah, there's only two therapies that we know of, I think, that can give you a remission without having to always take something, and that's transplantation, autologous or allogeneic, but autologous stem cell transplantation. I mean, when it first became available, maintenance was not the standard in patients. There's a small percentage. It's were they going to relapse? We all leave this earth, so perhaps they just did, passed away for other reasons. But there's a small percentage of patients that never relapse after stem cell on no maintenance, and we have patients that are a decade out on no maintenance. And the other is CAR T cell therapy. At least as of right now, there's no standard recommended post-CAR T maintenance, because patients can experience years of remission unmaintained. Otherwise, it's until disease progression or maybe over time that we learn, like in some other diseases, if you maintain a level of MRD negativity for a certain period of time, that you could potentially then withhold that therapy and watch them closely. And if they come out of remission, generally hope and expect that they would respond favorably to retreatment.
I have two questions regarding CAR T therapy. First one is the re-engineered T cell will die off. So how could you have remission for years after the first infusion without maintenance? And then the second part of my question is because of CAR T target BCMA, so your immune system will be impaired. So how careful you need to isolate yourself after the initial infusion? Thank you.
So the first question was how can you have years of remission when the T cells potentially might die off? A lot of these patients have measurable CAR T cells, for a year or more after. We don't really understand fully how long they really need to be around to work, though. Is just killing off all the myeloma immediately good enough? Do they need to hang around forever? But sometimes you can even detect them, but they're not functional. So there's all sorts of different issues with trying to measure that. But those cells can potentially, remain in very, very low levels, maybe even undetectable levels for years. after the infusion. And then as far as immune deficiency or immunocompromise afterwards, I mean, it's probably the first few months after are going to be the most immune compromised, and, really all the cytokines going around, and, low immune system, and post lymphodepleting chemotherapy, neutropenia, and, plus the hypogammaglobulinemia. We'll often have a very low threshold for starting intravenous immune globulin for the first few months, and then after that, if the patient is doing well and not really having a lot of infections, we can back off on that. Just sort of like after a stem cell transplant, usually those first few months are going to be associated with the most immune compromise, and then after that, parts of the immune system sort of gradually recover. And but yeah, there's always going to be potentially some immune dysfunction, or because we still have depleted your plasma cells afterwards.
Yeah, I mean, again, knowing that this disease, most people, begins as MGUS, smoldering, myeloma. The deeper the remission you put somebody into, the longer that will last. And so the idea is that we're obtaining remissions that we haven't seen actually, even with transplant with CAR T, like rapid as well. And so the idea is that you're, getting them to this level of remission that takes that much longer to come out, even if the cells, so-called, and even testing for the presence of them is not it's not standardized as to how to monitor and what to do with it. Maybe if in other diseases, I mean, you're still monitoring the patient in either way, but maybe then you reinitiate some kind of maintenance perhaps. But I think, and we kind of do the same thing, I think certainly the first 3 months, we typically recommend patients keeping a pretty low profile, definitely low threshold to give IVIG if we can convince the payers to pay for it, which is an ongoing fight, at 3 to 6 months. And then usually we initiate sort of similar to the stem cell revaccination schedule after CAR T.
I might add one note that, CAR T therapy is, we don't fully understand still the biology of it. Even, going back to like when it started with Carl June at the University of Pennsylvania and looking at the lymphoma space, and now it's come over to myeloma. The fact that those CAR T cells can persist so long after says that the alteration to their biology is something really interesting. So they may not actually respond to like the normal cellular degradation that happens with normal lymphocytes, and how that then translates into the immuno alteration that we see with CAR T therapy. Those are just unknown questions, but it speaks to how interesting it really is.
Great, thank you. Oh, you have one more question?
So with infections, they treat the infection with an antibiotic. And I think over the years, there's been some question. Does the infection come back stronger when you stop, if you don't complete the cycle of antibiotics? It comes back, you take a little bit, and then it comes back. So myeloma, when it comes back, are the myeloma cells stronger, or are they exactly the same as they were?
Historically, with each successive line of treatment, the remission would last shorter and shorter because the treatments became less and less effective. We've sort of reversed that with T-cell therapies. It's actually gotten much deeper and longer with CAR T versus anything they've probably had before. But once it comes back after CAR T, then it could be very aggressive. Harder to treat.
With treatment, with each line of treatment, what's occurring with myeloma, this is true of all cancers really, and as you make the great analogy to infections, you're applying selective pressure. So those cells that are sensitive to X treatment are the ones that are going to die off, and what's left is by definition resistant to that. And when you keep doing that with successive generations, you have then more of a resistant population. That's kind of just, unfortunately, the way it is, and so you need something that's more potent, something more unique to then attack that further population. Yeah, at some point, like you just need soap, right?
Or salt.
Or salt. But that's an apt way to put it. And this is why then we look forward to that next line of treatment. We're just trying to get people to that next line. because that's what buys them increments. And those increments over the long run translates to years.
And that reminds me of something I wanted to mention earlier in my talk, and I forgot to mention, but we talked a little bit about sequencing of, CAR T and then bispecifics, because bispecific, patients that have had bispecifics don't really have great outcomes after CAR T. Part of that is felt to be because of the constant selective pressure of the constant injections of the bispecific antibodies, wearing down their T cells, but also it forces them to mutate their BCMA binding domain. So if you do tests to look for BCMA, you can still see it there usually, but it might just be mutated to where then the CAR T won't recognize it, or another bispecific won't recognize it anymore. Whereas when CAR Ts stop working, it's probably just because they've died off or they've become non-functional, and they typically haven't mutated their BCMA, and so that's why they can still often respond to bispecifics afterwards.
Somewhat the same with auto stem cell transplant. If you're old enough like me, like after, if you're on continuous maintenance, Revlimid, for instance, and you're progressed, then obviously it's going to be Revlimid refractory versus someone that has had 3-4 years of no therapy. They're more likely to respond to retreatment. But also to your, in addition to sort of changing the expression, but definitely probably they were there all along, but selectively you're often seeing new mutations that you might not have picked up early on that are often more aggressive and more refractory or resistant. So you're like selectively, you do what you have to do, but that's why it's not that clinically it may not be relevant yet, but it's not unreasonable to repeat the assessment of your disease chromosome analysis to see if there are new mutations, and there's some that may be actionable, if not now, but maybe soon.
It's also possible to regain sensitivity to treatment that they were not sensitive to, or have become resistant to early on. If it's been enough time or enough years, sometimes they can regain sensitivity, which is good, yeah.
Will be our last one.
How do you determine when and or if the post-transplant patient starts maintenance?
So most, outside of a trial, I usually the first 2-3 months after stem cell transplant, it's all about recovery. And so that's that period that I usually wait until they're about 3 months out, their counts are good, eating reasonably, back to normal. There are some maintenance trials that, initiate very early on post. And there's some that incorporate actually consolidation, additional therapies post stem cell. But usually you wait until there's sort of, I would say, sort of intestinal recovery, GI side effects. So usually in that 3 month plus 3 to 6 month range is when we do it.
And I would say, pretty much anybody that can and is willing to should do maintenance after an autologous stem cell transplant these days. The bigger question is lenalidomide alone enough, or do we need to combine it? And that has to do with, how deep of remission you're in on that 3-month restaging, what are your chromosomes, how high risk is your disease, all those sorts of things.
And in general, with maintenance therapies, transplant is very much kind of questioned, I think, more and more nowadays. But maintenance has really been a standard that we've had for a long time. And even for people who don't do transplant after induction, we actually still recommend a maintenance. It maintains the response. That's what we intend it to do.